over the last 5 years, but looks now really, really good. So I first will have just a tiny little bit about the background on MRI, just a few slides, and then I get back to the clinical use of MRI in term infants and also when to use the MRI in preterm infants. This is a picture taken from a book that we recently published, Neonatal Brain Injury. It's actually a open access book edited by Mohammed Khurshid and Gerda Weiler. So I really recommend it. It's easy to use and got a lot of nice pictures like this one shown here on the left. So we have to realize that a newborn brain consists for 95% of water, which is hard to imagine, but it's true. And during the first year, the water content goes down quite rapidly. But it's there, and we also have to realize that everything in our body is kind of electric. So there are protons, electrons, and they all kind of go around in all kind of directions, unless you put a baby in a scanner, and then the protons are aligned within the magnetic field. So when you are putting the baby in the scanner, then you want to see the tissues, you get a radio frequency pulse on, and then it kind of puts the protons out of alignment. And then when your radio frequency pulse is stopped, then they kind of start deflecting. But you can imagine that if you go through the fluid, like the CSF, this happens very rapidly. But if you go through the tissue, you got a different timeline, then it will go very slowly. And because for every tissue, also for injured tissue, this will be different, you can kind of get a lot of detail of the different tissues that you have in your brain or elsewhere in your body. And then we know that the T1 and T2 sequence are the ones that are most commonly used. They're also called the conventional MRI sequences. And they are obtained using different times of repetition, the TR, and times of echo, the TE, so echo time and repetition time. So the repetition time is the time that is between the application of the radio frequency pulse and the start of the next radio frequency pulse to the same area of tissue. While the echo time is the time between the application of the RF pulse and the peak of the echo detected. So the TE and the TR, they need to be specifically aimed at the neonatal brain. So if you're using adult sequences, you're not going to get any decent pictures to look at. And the TR affects the contrast on the T1 weighted images and the TE on the T2 weighted images. But the only thing you really have to remember when you're looking at the T1, you will see that the CSF is dark. And if you look at the T2, the CSF is highlighted, so white. So besides the T1 and the T2 sequence, we are also using the diffusion-weighted imaging, especially for babies with acute injury. Then you will see as bright the areas of acute ischemic injury. And the SWI stands for susceptibility weighted imaging. And this is a very helpful technique if you want to identify hemorrhagic lesions or calcifications or abnormal vessels. So for the vessels, we are using the MRA, the MR angiography, or the MRV, the MR venography, when you think about the sign of venous thrombosis. And then finally, for metabolic disorders, we are using the MRS, the MR spectroscopy, but that is also very useful for HIE because you can identify certain peaks, as I will show later. And one of them is lactate, which in babies with severe HIE will be increased. But it's easier to look at the images. And here we see these most common sequences that we are using. We are nowadays, most of us are using a 3 Tesla magnet. In the past, this was a 1.5 magnet. And now some people are also using the Embrace, which is a low field 1 Tesla magnet, which can be installed in the unit or room adjacent to the NICU. And this is also now becoming quite popular. It's also very important to remember that you need to have thin slices to see the detail that you would like to see. So if people are using 5 mm slices, then you're going faster through the brain, but you also lose a lot of data. So on the left, we see the T1, and as I mentioned, the CSF is dark, and the only thing which is white are the bright is the posterior limb of the internal capsule. So that's the only thing which is myelinated besides the brainstem in a full-term baby. And everything which we see now as dark gray will be white at the age of 2 years, because all these areas will by then be myelinated. Here we see the T2, and now we see that the CSF is bright. And we also see that the white matter is a little bit bright because, as I told you before, there's so much fluid, water in the brain, and that's what makes the white matter make it a little bit bright. Now here we see the diffusion. Here the abnormalities will show up as bright areas, as we'll see in our cases shortly. But in this child, everything is gray. So there are no areas of acute ischemia. And then you will probably tell me, well, there's something going on here at the bottom of the brain. But actually that is artifact, which you quite often see at the surface. And then on the far right, we are looking at the susceptibility weighted imaging. And here we beautifully can see the veins in the white matter over here. So this is a normal child showing these vessels very clearly. And we also see the vessel going through the germinal matrix into the terminal vein. But if there would be a hemorrhage, then there would be a large area of low signal intensity, of a black area, so to speak. So what are the indications? And I would like to start with the full-term babies and then end my talk with the preterm babies. So for the full-term babies, of course, most of us, I think in Holland, in Europe, it's kind of more or less obligatory. If you cool the baby, then after cooling, you will do an MRI. So that's more or less clinical practice. Babies with seizures, it's always worthwhile to do an MRI, even if they're not being cooled. And in 90% of the MRIs, we will identify the cause for the seizures in this baby. And then if we suspect a stroke, either an arterial ischemic stroke or a sinovenous thrombosis, it's very important to do an MRI as well. And for a suspected metabolic disorder or a CNS infection or a congenital infection, it's also important to consider doing an MRI. This is a nice image which comes from a paper that we recently published in pediatric research. And here we see the main patterns in drawings and on the diffusion, on the main patterns of injury in a baby with HIE. So on the left, we see a typical example of the watershed type of injury. And I'm showing you diffusion imaging because the abnormalities are most easily detected with diffusion. And we see here the bordery zones, so in between the main arteries, between the anterior and the middle, and between the posterior and the middle, we see these areas of diffusion restriction showing up as bright areas involving mostly the cortex and also a little bit of the underlying white matter. And that's what we call watershed type of injury. And the baby is following an acute sentinel event, so really like uterine rupture, placental abruption, prolapsed cord. We may see injury purely to the most metabolically active areas, the basal ganglia and the thalami. So we tend to call this a BGT pattern of injury. Now, we can also have injury where both the central gray nuclei as well as the cortex and white matter are affected. And this is what we tend to call the near total pattern of injury, so the most severe pattern of injury. And then we recently, we paid more attention. We recognized that the mammillary bodies, these tiny little round areas over here, and the hippocampi can also be involved and are important for subsequent outcome, especially memory and also total and performance IQ. So the question is always asked, when should we be performing our MRI? And here we are talking about the basal ganglia pattern of injury and the watershed pattern of injury. So in 2014, there was a paper by the American College of Obstetrician and Gynecologists, and they said, well, it's best to perform 2 MRIs. The first one you should perform early, between day 1 and 4, and doing it this early will also help you to time the onset of the injury, and then repeat it on day 10, well, between day 10 and 21. But I find this quite difficult, because if you do it very early, on day 1 or day 2, you will not see the maximum extent of the injury. So in fact, it's a little bit too early. And also the baby needs to be removed from the NICU to the MR scanner in the middle of hypothermia. So we really would not like to do this. Now, if you do it beyond the first week, then you lose your diffusion, which is really something that you would like to look at, because it's so easy. And also many of our babies would either be transferred back to the local hospital, or even the ones that were not so severely affected will already be home. So it's also not very practical. There have been a few papers recently, one by Terry's and Mohammed's group, and another one that was just published in American Journal of Perinatology, showing that doing 2 MRIs is better. They both have about 100 babies. If we look at the top one, we see that 24% had milder injury in the second week. Well, that's basically because you do no longer see your diffusion abnormalities. And 16% had more severe injury. But in this paper, there are no examples, so it's difficult to know how important the changes were. Well, in the other paper by Mohammed's group, we have 94 babies, and 16% once again showed resolution of the injury on the second MRI, and 13% only showed injury on the second MRI. And 4 out of 76% had further evolution of injury on the second MRI. Well, then none of these 2 papers talk about the relation to subsequent outcome, so which MRI is most important. And in the paper by Mohammed, we do get a picture, but we see very, very tiny punctate lesions in the white matter. So you really wonder whether doing 2 MRIs is really necessary. What is really important is that don't do your MRI too early, because this is a very old paper from Jim Barkowitz from 2001. And we see on the top, it was performed on day 1, and you see only diffusion restriction in the thalami and nothing else. But then the baby had a second MRI on day 7, and now you see that the total area of the basal ganglia, the caudate nucleus, and the thalami, but also the peri-Orlandic cortex, are all affected. And so this will give you a completely different picture, and also a completely different talk to the parents about subsequent outcome. So please don't do it on day 1 or day 2. We sometimes do an MRI on day 3 when we are considering redirection of care, but we aim to do the MRI on day 4 or 5 after the baby has been rewarmed. Here we see another example, one of ours, a bit more recent. And now we see that initially on day 2, again, there's just injury to the thalami. And on day 5, we see that now the basal ganglia are also affected. And that's what we usually see. The injury starts in the thalami and then spreads to the basal ganglia and sometimes to the peri-Orlandic cortex as well. Also good to know here that we are looking at the diffusion-weighted imaging, where the injury is white, and the apparent diffusion coefficient, which is the reverse, and now the injury is dark. And the nice thing about the ADC is that you can measure a value, and this is helpful, because sometimes you don't really know whether it's abnormal or normal, and then measuring is always good to do. nice paper from Australia some years, more than 10 years ago now, where there were 3 radiologists and they were scoring the MRIs with or without diffusion-weighted imaging. And we see that the kappa between the 3 radiologists is a lot better, still not very, very good, but still a lot better when diffusion-weighted imaging was available. So now most of us recommend perform your MRI day 4 to 6 after rewarming when you still have access to your diffusion-weighted imaging, because important to know that by the end of the first week, you get what is called pseudo-normalization, so you lose these white areas at the end of the first week. So it's really a measure of acute injury. We did a meta-analysis some years ago, and here you see as well that the MRI in the first week has got higher sensitivity, specificity, and diagnostic odds ratio compared to when the MRI is performed in the second week. And this is mainly because diffusion-weighted imaging is present in the first week, and it makes life very, very simple because it's so easy to recognize these areas of increased signal intensity. And that also applies for the other type of injury, the subacute partial asphyxia, the watershed injury. And again, we see here that it's also best seen with diffusion-weighted imaging in the first week. Here we see the abnormalities very clearly, and here it's very hard to say that anything is going on. Maybe the signal is a little bit higher, but we still see the cortical ribbon, which you sometimes lose in severe watershed injury, but in this case, it still stands, it still looks normal. So also the corpus callosum, which is very often involved in the watershed type of injury, is very clearly seen on the diffusion-weighted imaging. Here we see another case, ultrasound, which of course we always do as well. We see that there is some echogenicity more pronounced than on the other side. We see that the sulci are a little bit fuzzy, which also is a little bit suspicious. But then if you look at the MRI, life is a little bit easier. Again, this high signal on the right side and also here posteriorly, and the diffusion showing the cortex being very much involved in this unilateral type of watershed injury. Here we have a baby who was not cooled. I think the baby should have been cooled. There were many things that kind of allowed the baby to get cooling, but still because of the rapid recovery and also the Thomson that we do in Europe being 0, as they said, it was decided not to cool this baby. But then at 10 hours, somebody did perform an ultrasound and was quite concerned about the amount of echogenicity that we are looking at, especially in the white matter, maybe a little bit in the thalami as well. And then the baby was put on the AEG, and you can see that right from the very beginning, there are repetitive seizures, which at this point, when the phenobarb was given, the seizures fortunately stopped. And then on day 4, an MRI was performed, and we see a low signal on the T1, and then we see this high signal in the right frontal lobe in the watershed type of distribution, and also some involvement of the thalamus on the right and the corpus callosum, and some milder changes on the left side. We see that on the 3 months MRI, we repeated it. We usually do when the children do have quite considerable abnormalities. We now see that the myelination has progressed. It is not only the posterior limb of the internal capsule, but also the optic radiation and the anterior limb of the internal capsule. But you see that there is considerable atrophy on the right frontal lobe side, and there are even some small cysts here as well. Now, fortunately, this baby has done very well with good Bailey scores at 2 years and now still also at 3.5 years. But we will need to see how the child is going to get on in school age, because these type of injuries, the watershed, they usually show that the children are not doing so well at school, that they get behavioral problems and also memory problems. To make life a little bit easier, we came up with a new scoring system in 2018 with Lauren Weke as the first author. And here we see all these kind of small pictures of the different problems that we can see on the MRI. And we score them as being focal or extensive, unilateral or bilateral. And all these points are added up for the deep gray matter, the white matter, the cortex, also the cerebellum, and also the spectroscopy if you have it. And then adding up the score, you can get to a maximum of 55. I think it's nice because it kind of forces you to look at all the little details. Here we see that the child also has got an IVH. Here we see that the cerebellum has got a very high signal on the diffusion. And here we see that the baby has got a sinovenous thrombosis. And here we see the punctate lesions in the white matter. So rather than just say basal ganglia, white matter, we looked at all the details that can be seen on the scan. And here we see the table that is in the paper with the MRI scoring form. And it is, if you've done it a few times, it's really very easy to do. And if you can get your radiologist to do it, then you have got it a kind of definite report in the notes as well, which is helpful. But you can also do it yourself because it's really not difficult to perform. And then you get really good prediction for outcome at 2 years, but also for outcome at school age. And we produce a graph for the gray matter score, which is most often related to outcome. And you see that it goes up very steeply. And if you're above 12, then you get a very, very high risk of an abnormal outcome. Then spectroscopy, I think it's available now on almost all the magnets. And if you talk to your radiologist, you can ask whether he can try to do it as well. We usually take a sample from the basal ganglia thalamic region, and then you can get these peaks. And this is most easiest, the choline, which is in the membranes, the creatine for energetics, and the N-aspartate, which is present in the neurons and also the axons. And then the lactate peak, you really don't want to see a high peak, but a little bit of lactate is shown here. And this can be very high in children with severe HIE. Now, looking at the paper by the group in London with Peter Lally as the first author in 2018, and they looked at all these different things, the clinical assessment, CFM, MRI, also the DTI, but the spectroscopy comes out as being the best area under the curve compared to all the other techniques. So it isn't difficult to do. It doesn't take long on your scanner. It's just about 5 minutes. So if it can be done, it can be really helpful and predictive of outcome. So when best to perform an MRI in children with stroke, either arterial ischemic stroke or sinovenous thrombosis? Ultrasound is good, and I really like it. I always do it. But for the stroke, you need to be patient. And if a baby comes in with seizure and you really want to know why the baby is seizing, then very often you don't have the patience to wait for the echogenicity to become apparent or after the first 48 hours or so. This is a very big stroke. You get this kind of linear demarcation line of the left middle cerebral artery area. You get compression of the ventricle on the affected side. In this case, you even see a midline shift. So this one you will probably see by the second day of life. This is a nice paper where they looked at only the middle cerebral artery, and they show that by 48 hours there is a good sensitivity, especially for people who have experience in doing cranial ultrasound. But we've taken to MRI very much, and especially again, the diffusion-weighted imaging is extremely helpful. And we kind of came up with a term which is called pre-Wallerian degeneration. Well, I think many of you have heard of Wallerian degeneration, and Wallerian degeneration indicates that there's atrophy of an area, a region, which doesn't get input from areas above. So your area here, the peduncle, is becoming very atrophic because there's so much area of destruction higher up that should kind of give the input to the peduncle. We are looking here at the diffusion, and we can see the prevalary degeneration in the cortical spinal tracts and in the cerebral peduncle. And we know that if we see this, that is bad news for motor outcome, because it's very, very likely the child is going to develop hemiparesis. And in a coronal view, you can see the cortical spinal tracts descending here towards the pons and the brainstem. Now, the middle part of the peduncle and the middle part of the posterior limb of the internal capsules are exactly the areas where the motor tracks go through. So if you see that they are highlighted on an early diffusion, then you know the child is at risk of developing motor problems. And this has been reported by many groups now. It's also very nice that if you do an MRI in the first week and you do not see involvement of the cortical spinal tracts or the cerebral peduncle, you can tell the parents that it's unlikely that the child is going to get motor problems. We see that. Here we see what I mentioned before, loss of the cortical ribbon. You see that there's an area of high signal intensity, easier to see on the diffusion that it's abnormal. And then at 3 months, there is some cavitation over here, but the posterior limb of the internal capsule is preserved, and the child had a good, no motor problems later on. Now, again, you don't have to be too fast. It's always better to be a little bit reluctant to do a scan immediately, like in the HIE baby. And also for the pre-Valerian degeneration, we can see over here that on the first scan on day 2, we do not see the cerebral peduncle, while we do on day 4, and the same applies for the cortical spinal tracts. So also the diffusion abnormalities of the cortical spinal tracts, they take a little bit of time to develop. We did a study together with Francis Cowan in London, looking at all the subtypes of the strokes for the main or the anterior or the middle or the posterior middle cerebral artery, just a cortical stroke, a lenticular striate, a perforator stroke, and then a posterior or an anterior stroke. And then we paid a lot of detail to the posterior limb and the cerebral peduncle. Was it really the middle part that was involved? And then we looked at the outcome of these children and came up with this table. And I think this table is very helpful when you talk to the parents. So people always tend to say, well, if you have a stroke, then you have a 30% risk of developing cerebral palsy. And yes, that's correct. When you look at the whole population here of 161 babies, then indeed almost a third did develop a hemiparesis. But if you look at the children with a main branch, so this huge MCA, then all the children developed a hemiparesis, and half of them developed a visual field defect. But if you look at the children with, for instance, a posterior MCA, it's only 21%, and still some children with visual field defect, but none of the other subtypes did develop visual field defects. So it's really important to kind of get some tailor-made precision medicine and talk to the parents about their baby and look at where the baby did in fact have a stroke. So I find this table helpful when talking to the parents. What about sinovenous thrombosis? Well, very often this diagnosis is made with ultrasound. This was a baby in a level 2 hospital with mild HIE. It was not transferred for cooling, but they did do an ultrasound, and then they picked up that there was a dilated superior sagittal sinus, and there's some material in there which didn't look right. And then they put the Doppler signal in there, and there was no flow in the superior sagittal sinus. And then the baby was referred to us. And then an MRI was made, and then you really also need your MR venography. And we see that there is no flow as there should be in the superior sagittal sinus, while there is a lot of flow in the other sinuses. So the diagnosis was confirmed and the baby was anticoagulated with low molecular weight heparin for 3 months, and then the MRI was repeated, and we now see that there's perfect recanalization of the superior sagittal sinus. Here we see another baby that was diagnosed really late. The baby was irritable and was considered to have feeding problems, and it took a lot of time, and then the baby started to lie in an opistotonic posture, and then an ultrasound was done, and then the abnormalities were very severe with a huge area of ecodensity, a hemorrhage in the left thalamus, and also blood in the lateral ventricle. Well, a hemorrhage in the thalamus is really very, very suggestive of a thrombosis of the deep venous system. And this is what is shown on the MRI. First of all, we see the very large hemorrhage being dark on the T2 sequence, and we see on the T1 this thrombus being high signal, both in the superior sagittal sinus and also in the straight sinus, and the hemorrhage over here being bright as well. And then on the MRV, we see no flow in the superior sagittal sinus or in the deep venous system, the straight sinus. So this child also was anticoagulated and also had reopening of its superior sagittal sinus. And we do give anticoagulation even if there is a hemorrhage in the thalamus, and we haven't seen any complications of this. Then the baby was scanned again at 3 months and again at 2 years of age. And we see that there is good resolution of the hemorrhage, but the thalamus on the affected side has become smaller. The posterior limb doesn't look as nice, but these children usually do not develop a hemiparesis because the posterior limb of the internal capsule is not really affected. It's just the area adjacent to it. And we see that on the later T2, we can still see the dark signal of the previous hemorrhage. Now, the main problem in these children is not motor outcome, but these children are very much at risk of developing a certain type of epilepsy, and that is electrical status epilepticus during sleep, ESUS, but now the name has been changed to SWAS, spike wave activity during sleep. And that's not a very nice type of epilepsy, which results in cognitive decline and is difficult to treat with prednisone and clobazepam, but that's not always recovering from this ESUS or SWAS. Metabolic disorders, as I mentioned before, also very helpful. This is a very typical example of a child with severe hypoglycemia, symptomatic hypoglycemia with seizures. On the ultrasound, it's difficult to get to the posterior lobe where the injury is usually seen. We see here clear loss of the cortical ribbon. Here we see the black outline of the cortex, but here you lose it. And then on the diffusion, you clearly see the abnormalities. Also, the corpus callosum is affected. And then after 6 weeks, we see that there are a few cystic lesions and some atrophy. And again, these children are at risk of later epilepsy and cognitive problems as well. So here it's really important to perform an MRI in children with symptomatic hypoglycemia. Congenital infection. Here we see a child where the diagnosis was made of congenital CMV infection. The baby was microcephalic, had low platelets, and we see the typical ultrasound abnormalities with the lenticulostriate vasculopathy and also other areas of calcification and some mild ventricular dilatation. Now, when I'm giving a live talk, then I usually ask the audience, would you do an MRI? And well, many of them say no, because now we've got a diagnosis. So why would you like to do an MRI as well? It's unnecessary, but in fact, it's really important. because on the MRI, we see the occipital cyst more clearly than on ultrasound. But what is most important, that we see that the child has got a lot of polymicrogyria. So you see these tiny little worm-like surface of the brain rather than the normal cortical infolding, which you still see anteriorly. And again, if you talk to parents when the child has just got some germanolytic cyst and LSV, then you will talk about a different future than when you see this very, very extensive polymicrogyria in this child. So for congenital CMV, if there are ultrasound abnormalities, please also perform an MRI. And then the viral infections, I think they're very, very interesting. I know that in Australia, you had a lot of par-echovirus and more severe than we had in Europe. But this is a case of rotavirus, and all these viruses, rota, entero, par-echo, chikungunya, they all have the same kind of imaging pattern, looking a little bit like PVL, with the white matter, the cortical spinal tracts, and subsequent cystic evolution. But it's also very interesting, and I don't really understand that. If you would see this in a preterm baby, then you would say, oh, wow, this baby is going to get cerebral palsy, and the cortical spinal tracts are involved, and the baby is developing cysts. But the children with viral infections, they sometimes are performing much better than you would expect based on the imaging findings as shown here. And this baby was still normal without any signs of CP at 12 months, and some language delay I heard later at the age of 2 years, but still no evidence of cerebral palsy. So the children with seizures and a possible viral infection, again, I would recommend doing an early MRI to have benefit of your diffusion. So let's move for the last couple of minutes to the preterm baby. In the preterm baby, I would consider doing an MRI early if there is perinatal asphyxia and you consider redirection of care. If you have got a lot of echogenicity in the white matter and you're uncertain whether this is going to evolve into cystic lesions or not. And again, when there is a severe CNS infection. And for term equivalent age MRI, I would like an MRI if the child has got a periventricular hemorrhagic infarction, a grade 4, so to speak, and to look for asymmetry of myelination of the posterior limb of the internal capsule in children who did develop cystic PVL to see the extent, and also children who had post-hemorrhagic ventricular dilatation and needed neurosurgical intervention, a reservoir or a shunt. So here's an example of a large grade 4 periventricular hemorrhagic infarction. Here we see the pattern of the veins, the medullary veins. And we now know that if there is an obstruction here due to a bleed, there will be impaired venous drainage and you will get this type of injury. So it's not extending the IVH into the brain tissue, but it's impaired venous drainage. So on the early MRI, you just see a confirmation of the lesion, but I also like to see that the other side, which the baby is now dependent on, is actually not injured. And here we see that this is the case. It's purely the right hemisphere that has got this large hemorrhage. Now, of course, when you repeat this at term equivalent age, we place the reservoir. You can see it sitting here. There's still a little bit of a clot here. And at term equivalent age in this coronal T1, we see that the myelination of the internal capsule is only visible on the left side. So we can start early intervention. We can tell the parents that, yes, the child is going to develop a hemiplegia, but the left hemisphere looks okay. So hopefully the child is going to be kind of reasonable, okay. Another type of PVHI, sometimes mistaken for unilateral cystic PVL, but that's obviously not the case. There's a large IVH. There is just in this kind of triangular shape echogenicity, which is confirmed to be hemorrhage on this early MRI. And then at the term equivalent MRI, we see that there is cystic evolution, just a single cyst. that is not communicating with the lateral ventricle. And we see that there is not complete absence, but kind of mild asymmetry of the myelination. And this child developed a mild hemiparesis later on. You can also bring this forward and say, hey, this diffusion, it was so helpful. Why are we not using it in these babies? Well, I think it's very helpful once again, because now we can see again at the early MRI that the middle part of the posterior limb is indeed diffusion restricted. So we know already in the first week that the child is going to develop a hemiparesis, and we also see a little bit of highlighting of the cerebral peduncle. And this is at term equivalent age, the cystic evolution, and the child on another level also had asymmetry of myelination. So here it can also definitely be very helpful to have an early MRI. So what about the echogenicity? Well, I think here again it is helpful. This baby had some degree of perinatal asphyxia, and there's inhomogeneous echogenicity on your ultrasound. But is this really severe? Will the baby develop cyst? Or is it kind of less severe but still of some concern? Now, if you then do an early MRI, then you will see with this inhomogeneous echogenicity some punctate lesions in the white matter, and in this case they're quite extensive. We see them on the diffusion in the first week. We see the posterior part of the posterior limb, a little bit of the thalamus, optic radiation, and we know that if there are more than 6 punctate lesions, there is some concern about subsequent outcome. But we also know that if you see these punctate lesions, then you're not going to get a kind of cystic PVL grade 3. It's not going to evolve into extensive cystic lesions. So these punctate lesions, here we see them very clearly, very kind of many of them in the white matter, widespread on the diffusion, on the ADC map, and not on the susceptibility weighted images. So these are not hemorrhages, what people sometimes say because they are low signal on the T2 sequence. But more than 6 are likely to be significant. Now, Stephen Miller had this nice paper some years back and said, well, it's good to make life simple. So let's make a simple white matter injury imaging rule. And when you see these punctate lesions in the white matter and you go to the level of the mid ventricles and you draw this line across the middle, then only the children who had lesions beyond and anterior to the yellow line developed an abnormal outcome. But if you only had lesions posterior to this yellow line, then the children did not have any problems at the age of 4.5 years. So this is nice, making life simple, and can be used on your kind of early MRI when the punctate lesions are more clear than on your term equivalent age MRI. Punctate lesions can be seen on ultrasound sometimes quite clearly. Here we see a child with an E. coli meningitis. We see them here. We see them at term equivalent age, very similar to what we now see on the T1 sequence at term equivalent age. This baby is still young, but I would be concerned, especially on the right side, as they go above this line that you could draw across. And at the same time, in this baby with meningitis, we also look at the mastoid view with the transverse sinus. We see beautiful flow here on the right side, but we do not see any flow on the left side. And on the early MRI, we see that there is a sign of venous thrombosis, as we can encounter in children with a meningitis. So MRI provides confirmation of the sign of venous thrombosis and also more anatomical detail of the white matter. A child with severe perinatal asphyxia at 31 weeks. So here the MRI was done because consideration of redirection of care. A lot of echogenicity on the ultrasound over here. On the T2 sequence, there's the IVH. It's more difficult to imagine how much injury there is, but on the diffusion, you see that the whole white matter is now diffusion restricted. And if we see these confluent areas of diffusion restriction, we know the child is going to develop cysts. So in this case, this led to redirection of care. In this case, the baby survived, and again, perinatal asphyxia. The mom was very, very ill and very severe echogenicity on the ultrasound. An MRI was performed. Again, we see confluent diffusion restriction, involvement of the cortical spinal tracts, and we see that subsequently the baby had severe cystic lesions and a very poor outcome. So there are a couple of papers that say if you do your diffusion in the first week, when you see a lot of echogenicity, that this may be predictive whether the child is going to have cystic evolution or not. And another child with perinatal asphyxia, and again, quite severe abnormalities already on ultrasound, more on the right than on the left side. We see it over here, but also on the left we see some echogenicities. There's also a genesis of the septum pellucidum, the echogenicities on the sagittal plane, and then the MRI, again, the diffusion is more helpful than the T2 sequence, and we see very extensive abnormalities here. And this baby actually died due to multi-organ failure. And finally, a child with very severe HIE. And here we see what we also see in our Fulter babies, this near total pattern of injury with diffusion restriction everywhere in the brain, except for the cerebellum, also the cerebral peduncles and the cortical spinal tracts, and some hemorrhages that we also saw on the ultrasound scan. So we did a paper about the asphyxia in the preterm and their MRI findings last year. And we noted that preterm babies, they also have problems. If they are extremely preterm, they are more likely to develop an IVH. If they're late preterm, 32 to 36 weeks, then they more often have white matter injury or deep gray matter problems. Cerebellar, the last slide, I think, the cerebellar hemorrhage. Well, we can sometimes see it with ultrasound using the anterior fontanelle, but here on the mastoid window, we see it much more clearly, a large area of echogenicity, and at term equivalent age, we see that it has become very atrophic and cystic. The early MRI shows the severe lesion on the right cerebellar hemisphere, and at term equivalent age, we see that the right cerebellar hemisphere is mostly gone, and supratentorial, the brain looks actually very nice with normal myelination of the posterior limb. And the baby was seen at 6 months so far and had a normal Hein assessment. So I'm not talking about advanced MRI techniques. They look spectacular. It's more a research tool still, volumetrics, diffusion tensor injuring, tractography, looking at the cortical surface, the thickness of the cortex. And I think these are all especially indicated for research purposes, and they're more related to cognitive outcome than specifically looking for motor outcome. I think they are becoming a little bit more widespread, but not very much so. And they look at the population rather than an individual patient. So if you got these kind of images and you're talking to the parents the next day in clinic, then it's very hard to tell them anything about these nice colored pictures. But if you look at the whole population and say, well, in this baby, the volume of the cerebellum, all of them was a little bit smaller, and it's related to cognitive outcome, then it can be very, very interesting and a good research tool. So to conclude, serial quality, good quality ultrasound is still really very important. We should not forget that, and we won't. Two techniques are really complementary. The MRI is especially helpful when you do it within the diffusion window, so the first week after the injury. The MRI is also important when you try to predict cognitive outcome, but then you need more often to use these advanced imaging tools. And I think AI will also probably play an important role in MRI in the kind of very near future. So just a picture of all the people I've been working with over kind of 40 years, I would say. Floris Groenendaal has been my main colleague in Utrecht. I started my work in London with Francis Cowan, and we still collaborate. And at present, I'm working together with Silke Steggerda in Leiden. And then, of course, there are many people from many centers that I've been very grateful that I've been able to work with them. And I would like to thank you for your attention.
Thanks, Linda. That was a magnificent overview about MRI. Thank you so much. You took us to, the main group, the term infants with HIE, the importance of diffusion-weighted images and how that can add information, and then you showed that in cases. You tipped on MRS, and there's some questions which are going to follow soon, where then you went to stroke, and I really like. You actually almost said like, well, maybe you should wait a bit, which is another question which will follow, and that pre-Wallerian damage was something new to me, which is really important, to sinus venosus thrombosis infections, and then the overview of the preterms, which remains a challenging task to at least again time the MRIs and what information you get from them. There's some questions in the text in the chat box. The first is by Gayatri about the role of MRS in preterm brain injury.
Yeah, it is not used a lot in a preterm baby. Floris Groenendaal actually had a review paper about this last year or the year before. And again, it can be of some help, but I think it's still early days to be doing it in all our preterm babies. But there certainly are some studies suggesting that it can be helpful in this population as well, also related to motor as well as cognitive outcome.
And sort of a follow-up on that, in our term babies, I remember when I came here in Newcastle, we used to have it, and then it sort of stopped, and it sort of never came back. So you just need to specifically ask your radiologist, now, can I have MRS?
Yes, it's always good to be sitting next to your radiology technician and tell them where to go. So what we usually did in Utrecht and Leiden is to take the left basal ganglia thalamic area, and then you have to be careful not to be touching on the fluid, the CSF, because the lactate may be higher in one area, and you really want to specifically look at the brain tissue. But if you take a voxel, an area region of interest in that specific region, that's what most people do. And then it all goes automatically nowadays, and then you get the spectrum and you can assess it. So it doesn't take long, it takes about 5 minutes, and I think it's available on most machines now.
Okay, thank you. Simone Huntingford has a question about the best timing for non-cooled HIE babies. Is that different than to cooled babies?
Not very different. You can maybe do it if you want to, you can do it a little bit earlier. Don't specifically have to wait till rewarming. But again, I would not do it before day 3 because again, you will not have the full extent of the injury. A very old paper by Barkowicz was also, of course, done before cooling, but within the first week. For the cooled babies, the low ADC values, so the diffusion window is a little bit longer than in the normothermic babies.
You mentioned in your talk actually quite a lot of referrals to the ultrasound, which is indeed usually the first tool which is used. The progress in ultrasound, particularly in quality and in resolution, in depth and things, has gone up, quite significantly. Does that impact those whitening or more white-looking areas or not?
Well, I agree. I mean, ultrasound is a magnificent tool, but it still has got its limitations. I think in the HIE population, MRI is really the gold standard. I think we always should be doing an MRI in babies who have been cooled or babies having seizures. We still do not get to the surface of the brain, so polymicrogyria is still very difficult in most children to see with ultrasound. And as I showed a couple of samples of HIE, the preterm baby, I think you also get much more information there than just doing ultrasound. So I think, as they always have been, but they still are, they're complementary tools.
This is an interesting question. Charles Barfield asked about the lactate in HIE. Say you do your MRI on day 4, you already went through your neurocritical care phase. Why is the lactate still high on MRS?
I think it can actually be high for a prolonged period of time. Even after the first week, you can still see your, I think the tissue still has to kind of recover, even though there has been hypothermia. And it also shows you that this tissue is really injured. And there usually is a good correlation between the height of your lactate peak and the amount of diffusion abnormalities you see in the basal ganglia. And your NAA, again, the NAA is different. The NAA may be preserved the first couple of days and then kind of comes down over the next couple of days and may be lower, especially after the first week. And the NAA is more predictive of subsequent cognitive outcome.
Is there something that we as clinicians can do to modulate that?
Well,
Hemodynamically, or, what can we do besides cooling,
besides cooling, well, yes, maintain the baby as stable as possible is always a good thing to do, of course. We are waiting for the magic bullet. Maybe the melatonin that is coming our way is going to help. But I think other than cooling at present and keeping the baby as stable as possible, I don't think there's anything else that we can do right now.
There's another question here. The risk of SWAS, is that still there if you have a small thalamic lesion?
Yeah, the site of the lesion is very important. If the lesion in the thalamus is against the midline, the risk of SWAS is especially high. But if it's really almost, we did a study for the babies with a thalamic hemorrhage following CSVT, and 80% of the babies 8-0 developed SWAS. So incredibly high number, and that's why we started doing routine EEG from the age of 2.5 years onward every other year, because it's clinically often silent because it happens during the night, and some babies also develop seizures during the day, but many don't. So before the children tail off in their cognitive outcome, you would like to catch it and start treating it. So the site of the thalamic bleed is very important. And if they're very big, yes, then it's even more certain. But in fact, most of them develop SWAS.
Well, now that's really important for us as clinicians to refer to your neurologist if you find a thalamic lesion or an SVT, to at least follow up on these particular outcomes, because I was not aware that was happening. Penny has a question about, you do these ultrasounds in the preterm infants, and if you find an incidental sort of thalamic echogenicity, is that the same thing, or should be treated the same or different?
Well, it depends what it is. I mean, there could be a small perforator stroke in the thalamus in a preterm baby, and then, yeah, they usually do quite well later on. It's not that we do an MRI in every single child. I think it's mainly when your ultrasound is a little bit undecided and you don't really know for certain whether it's something significant or not, and you want to add on your ultrasound. Also, often it's helpful to perform a few ultrasound, and some of the echogenicities, they will kind of resolve spontaneously within a couple of days, and then you can also be kind of reassuring to the parents that it's not meaning very much. But it can be calcium, which is in the thalamus, LSV, then we also would not do an MRI. So not always. It's a nice tool, but you don't need to do it in every baby.
All right, it's past 6. Your day is about to begin. Ours is about to end. I want to thank you so much for presenting for us with this very, very nice overview. And thanks everybody for attending again to these webinars. I think we're back next week. I'm not 100% sure. Otherwise, we'll be back after PAS. Thanks, Linda. And thanks everybody.
Thanks, Linda.
Thank you. Bye bye.
Bye.